Welcome to Series 1 of the Latte Lounge podcast. Join me, Katie Taylor, as we talk balancing hormones, busting myths, breaking taboos, boosting libidos, and bolstering confidence. Why not grab a coffee, take a seat, and join us in the Latte Lounge as we chat all things midlife, menopause, and beyond. With thanks to our friends at Silk Natural Lubricant for making this podcast possible. In this episode, I'm going to be talking to GP and author of The M Word, Everything You Need to Know About Menopause, Dr. Philippa Kaye. We'll be discussing what happens to our hormones in our 40s, 50s and beyond, including helping you to understand the difference between pre, peri and post-menopause. We will also be examining the impact of our fluctuating hormones on our bodies and minds, and discussing what treatment options are available. As well as being the Latte Lounge's resident doctor, Dr. Kaye is also the medical expert for many well-known women's magazines, national newspapers, and appears regularly as the resident doctor on This Morning. She's also an ambassador for Joe's Cervical Cancer Trust and the Eve Appeal charity. So welcome, Philippa, and thanks so much for coming on to talk about this. So let's jump straight in, and maybe you can talk about, what actually happens to our hormones as we age.
So I always say that we are particularly kind to teenagers because we understand that in teenagers that they are responding to their hormones all over their bodies, and we definitely need to be kinder to women because the same is true. Now, you are essentially born with all the eggs in the ovary that you are ever going to have, and by the time you get to puberty, you've already lost loads of them, and then during the menstrual cycle each month you lose an egg, sometimes two, and when you run out, essentially, that's when the menopause occurs, and the menopause means the last period. Now, in that lead up to the menopause, which is the time called the perimenopause, there are already hormonal changes going on, because although your brain is involved in that menstrual cycle, your ovaries are too. So your brain stimulates your ovary to produce estrogen, which is what makes follicles develop and then an egg pop out. And then once that egg has popped out, where it came from, the sort of shell, which is called the corpus luteum, is involved in the production of progesterone. Now, if we don't have a menstrual cycle anymore, that means that we don't produce those hormones in the same way anymore. And when we test, which we do for younger adults, not for women over the age of 45, what we look for is those hormones in the brain going really high, going, come on, ovary, let's go, let's go. You need loads of this to try and make it work, but there's no eggs left, so you can't. And that means that the amount of estrogen and progesterone and also testosterone falls significantly. And it is that fall in hormones which then leads to all the symptoms.
And, we don't learn about this in school, do we? So we sort of learn about giving birth or not getting pregnant. And then you might hear the sort of word menopause sort of somewhere in the distance, and you kind of think of it as your mum or some sort of grey-haired old lady fanning herself, on a rocking chair. But I know, from my own personal experience and thousands of women we speak to, that doesn't reflect the women we are. So can you explain sort of what this middle bit is? I know often it starts, well, for me it did early 40s, this perimenopause that we never hear about, but obviously there are women, aren't there, earlier that can go through sort of earlier menopause symptoms.
So thankfully, learning about the menopause is now part of the secondary school PHSE curriculum. And I think it's really important because as a society for generations, we haven't talked about the health needs of women. And too often they're brushed under the carpet, and in lots of cultures and demographics, there is a lot of shame and stigma associated with these symptoms. So I think it's really important that we start actually talking about it at the same time that you learn about how to get pregnant, how not to get pregnant, the menstrual cycle, because it is part of life. And I also think that means that all genders need to learn about it, because everybody's going to have a mother, a sister, a partner, a friend, a work colleague that's going to go through it. And so this isn't something that's just for women in their 40s to learn about. It's for everyone to learn about. Now, in that perimenopause, the ovulation may become more irregular. Sometimes people will notice that their periods actually come more frequently, and other people, they notice that it stretches further apart. And those hormonal changes can be really erratic. So 1 month you might have a normal level of estrogen, and the next month it might fall to its boots. And then the next month go back to normal. And actually your brain is trying to keep up with these really rapidly plummeting, changing back to normal levels of hormones. And that's actually why symptoms can sometimes be more severe. And then as you go through the menopause, and that means that you've had your last period, and it's a definition of retrospect, a diagnosis of retrospect. We look back and we say you haven't had a period in a year. Often needs will be high. And then over time, your brain essentially rewires a bit. And some women find that their symptoms improve. Others don't. But symptoms can start a decade before and continue for many, many years afterwards. And when we're talking about those kind of symptoms, I'm talking about those really common ones: hot flushes, sweats, brain fog, irritability. But actually, if we think about the menopause as a long-term estrogen deficiency state, there are medium and long-term effects of that. So people often talk about things like genitourinary syndrome of the menopause, which is when the tissues of the vagina, vulva, and the urinary system become less elastic and dry, and you might get pain, burning, itching, pain during sex, recurrent urinary tract infections. That doesn't tend to happen straight away. That happens more in the medium term. And then in the longer term, you're at more increased risk of conditions like osteoporosis. So although those hot flushes might go away after a period of time, actually you may notice that other symptoms and concerns come on. And so we are governed by our hormones, our changing hormones, our lack of hormones from before puberty all the way.
And it's interesting because actually for me, and again, lots of women I hear from all the time, I never had hot flushes and I was still having periods. And that's why I had this misdiagnosis of depression, because I had psychological symptoms. And I've told my story many times before of going back and forward to different doctors and specialists trying to join those dots. And I think it's important that women realize that there are these sort of other symptoms of the low mood, the teariness, the anxiety, strange things like heart palpitations. I mean, I've heard of women with things like, burning mouth and obviously itchy skin. So I think, it's really hard. I mean, you GPs work so hard, and I know you only have a 10-minute appointment, can't possibly be specialists in everything. But I think that's why it's so important that we're empowering, women, healthcare professionals, men, children, everybody, so that we're all kind of working together, and especially educating through school so that we're all aware of these symptoms. So look, when you have a patient come and see you, how do you diagnose? How do you make that diagnosis?
Well, first of all, we have to remember that although the average age of the menopause is 50-51 in the UK, the perimenopause can start in the years before that. But actually, 1 in 100 women will go through an earlier menopause. And so you can have a menopause under 30, under 20. And so it is something that we need to consider actually at all stages of life. Now, the NICE guidance says that you should do blood tests, definitely in somebody under the age of 40, often under the age of 45. But after 45, we would go on your symptoms alone. And that's because those hormone levels can fluctuate so much. But sort of under the age of 40, I want to know something else going on as well. Is there another cause? Is there a reversible cause? Maybe there's something wrong with your thyroid, for example. So it's really important that you know what the symptoms are. And when somebody comes to me with a list of symptoms, and people worry and they go, oh gosh, I'm so sorry, I brought a list, or I brought a newspaper article, or I downloaded the Balance app or something, and I've made a list of all my symptoms. I'm so sorry, they say. And I always say, you don't need to apologize. You and I are on the same team here, right? We're both trying to work out what's going on. And if you've been reading, and if you've got empowered, then actually all you're showing me is that you also want to get better, and and that's great, and we'll work it out together. And if you're going to websites that don't have any evidence base around them, then I will look at that and I will say, do you know what, there isn't evidence here. And if you show me something that I don't know, then I'm going to go away and look it up, and maybe I'll learn something too. And and we can find our way together. I think that it's about the combination of symptoms often, and you don't have to have all of them, and you don't have to have them to a different degree of severity, and you can still have periods. periods or not. And people often associate, they say, I didn't come until my periods ended. And actually, the time to come is when your symptoms are bothering you. In the past week alone, I've had people who have been to see joint specialists, bone specialists, psychiatrists, cardiologists. They've been referred to all kinds of people for all kinds of symptoms, but no one's connected the dots. And essentially, often your GP is the best port of call for that, because we look at the whole body and the whole of you, as opposed to just one part of it. And so the commonest symptom that people are aware of are the hot flushes and sweats. Your mum hanging out of a window and having an argument with your dad over the thermostat. But other things which are common: joint aches and pains, palpitations, so an awareness of your heartbeat or your heart racing, dry, itchy skin, changes to your body odor, changes to how much you sweat, waking up at night sweating, not being able to sleep, feeling exhausted even if you can sleep. Yes, you can get burning mouth, you can get lightning shock sensations in your body, and then you can have mental health symptoms such as, again, I'm going to put insomnia in that category as well, and I actually put loss of libido in both the physical category and in the psychological category. Low mood, depression, anxiety, irritability, what we call the menopausal brain fog, which is difficulties with memory and concentration. People come to me all the time in their 40s and they say, I am terrified, I think I've got dementia. Or they say, I'm too afraid to get in the car anymore, because driving a car, actually, you need to do lots of different things all at the same time, and suddenly they don't want to get in the car anymore. And then that has a huge impact on the rest of their lives. And so there are lots of different symptoms like that. And yes, there are also aesthetic symptoms. You might notice that you lay down weight in different places, changes to your skin, changes to your breasts as well. So it is a whole body condition, and we need to think about it like that. And when somebody comes into me and they start talking about one symptom, part of my job, bearing in mind that, I don't know what you're walking through the door with at all. So we start off with the whole of medicine, and then you say joints, or you say heart, or you say a cough, and we get narrower and narrower, is to ask questions to rule out some things and make other things more likely. And so often I will ask that list of questions, I will ask that list of symptoms. And as I ask and people say yes, no, you can see that light switch turn on as they go, oh, actually, yes, I do have itchy skin. Oh, yes, my knee's killing me. Oh, yes, I'm just so irritable at work. Do you think they could be connected? And the answer is often yes. It's not always, though, the menopause. And I think that when we talk about the menopause and perimenopause so much, it's important to say it's not always the answer, and that there are lots of other conditions that could be going on. And so we mustn't get too one track, but it's important to always consider it.
And hats off to you guys. You're literally like detectives trying to sort of narrow down what's going on. And you're absolutely right. And we don't want to frighten women. There are lots of people out there who will sort of quote sail through. There'll be some who can manage just about, they'll get the odd symptoms. And then obviously there's the category who just are really not coping at all.
So let's put some numbers to that. Okay.
Yeah.
So about 1 in 5 women won't have symptoms. That means 4 out of 5 women will have symptoms. And within that, about a quarter of them have really severe symptoms, to the extent that 1 in 10 will have had thoughts about suicide. So there is that huge variation. We are all on a line somewhere, as we are for so many things. The point of when to go to the doctor and my answer of when it bothers you will change from person to person, and also will change as society changes to talk about it more. Because you can't change all those voices in your head that you've been brought up with. You can learn to deal with them, you can learn to accept them, you can learn to make another voice louder, but you have been shaped by that. Things where people might have said, don't talk about your periods, shh, that's private. Things where people have said, don't talk about sex, women shouldn't enjoy sex, they shouldn't have pleasure from sex, and as you get older, you mustn't have sex, right? None of these things are true, but they might have been things that you've heard. And so the point of when it bothers you will change from person to person, but also culturally, and may also change in the future.
Absolutely. And I think, like anything in medicine, it's about sort of extending length of life and quality of life. And I know for me, my quality of life was absolutely shambolic. I left my job, I became a shell of a woman, I put on weight, I spent the whole day lying on a couch, and that was, the journey, again, I hear all the time. So look, let's talk about treatment options, because we've talked a lot about the effects of having a lack of estrogen in our bodies and progesterone, and you touched very sort of quickly and lightly on testosterone, but so many women think, oh my God, testosterone, that's for men, and I'm going to grow a beard. So can we talk about treatment options, and sort of, obviously we must include the category, again, women like me who have had a hysterectomy, and also those that have gone into a medically induced menopause, perhaps through cancer treatments.
So firstly, let's just go back to testosterone. Testosterone is a hormone which all genders have, both sexes have, and women produce less of it than men, but we produce some of it, and it has roles all over the body, from things like brain health and cognition to muscle mass, bearing in mind that you have less muscle as you get older, and muscle is very anti-inflammatory, and actually we want to maintain that muscle mass, to libido and energy. So it has lots of roles, and levels after the menopause often fall, and often that's the last little piece of the puzzle, is a little bit of testosterone. So treatment options. It is important to know that you don't have to do anything. It's entirely up to you. No one is forcing hormones on you or another medical treatment on you. And there are lots of things that you can do yourself to ease your symptoms at whatever stage of life you are at. The first is avoiding smoking, avoiding caffeine for hot flushes. Spicy foods can trigger hot flushes. Making sure that you wear, it sounds simple, but makes a difference, making sure that you're wearing layers so you can peel off layers as opposed to one hot jumper. Exercise is hugely beneficial. I'm going to rephrase that to physical activity. I don't need you running up and down the netball court or a London marathon if that's not what your thing is. If that's your thing, marvelous, you won't find me running a marathon. But anyway, but exercise, although if you're not someone that exercises normally, and initially it might trigger hot flushes, but actually in the long term it reduces them. It's good for your bone health, it's good for your mental health, it's good for your sleep, it's good for everything. So there are things that you can do, making sure that you have a healthy, balanced diet. There are lots of lifestyle things. If you want to consider treatment, there are options. Now, hormone replacement therapy is like whatever that advert was, does what it says on the tin. It replaces the hormones which are lost or have become lower. Now, if you've had a surgical menopause, so your ovaries have been removed, generally for cancer treatment, for example, and that is premature, before the age of 50, there is no increased risk, or if you have a premature menopause for any reason, there is no increased risk to having HRT before the age of 50, because you are simply replacing the hormones which would otherwise be there, and in fact decreasing your risk of conditions like osteoporosis. So I think that that's really important to say that some groups, it may be more beneficial to have HRT for, especially now if you're going through a surgical menopause in your 20s, for example. But for everybody, whether or not you have periods, you can still take HRT, but the way that we give you that HRT might be slightly different. So some people might have an HRT that gives them regular bleeds because they were having regular bleeds, and other people who weren't having bleeds, for example, will have a form on which they generally don't bleed. If you have a womb, you need to have estrogen and progesterone. Think of estrogen like, I'm looking out the window and there's a patch of grass. Estrogen is like your grass seed sunlight, okay? So the grass is going to grow. The lining of your womb is going to grow and grow and grow. If I let it grow forever, I'm going to get some weeds in there. And so the lining of the womb becomes very, very thick, and that increases the risk of womb cancer. Progesterone is like your lawnmower. Comes along, stabilizes the womb lining, and therefore decreases that risk. So if you have a womb, you need to have estrogen and progesterone. So how we give that progesterone might cause a bleed, might not. If you don't have a womb, if you had a hysterectomy, maybe for fibroids, maybe for whatever reason, you can have estrogen alone. You don't need something to stabilize that womb lining because you don't have one. And then once you are estrogen replete, so we know that actually you're on good doses of estrogen, if you're still having symptoms, for example, particularly of fatigue and low libido, adding in a little bit of testosterone can make the difference. But if you come to me and you say, I don't want HRT, the first question I'm going to ask is why? Because there's a lot of misinformation out there. There are a lot of horror stories. And the first thing is, do you know what the facts are about HRT? Have you been told, for example, or do you remember that you couldn't have the combined oral contraceptive pill because you have migraines, and then assume that that means that you can't have HRT? That's not correct, you can. Or you might say, oh, my gran had breast cancer, I'm worried, I don't think that I can. Actually, you can. And so first is why, what's the reason? And let's talk about that reason. But if you say, let's say that there is a medical reason why you can't, or you say, I just don't want to, that's fine. There are lots of other options out there. There are non-hormonal options out there. There's a medication called clonidine, which is licensed for treatment of perimenopausal or menopausal symptoms. It often has side effects. It's not my first choice, but it is out there. We can use various kinds of antidepressants and anti-seizure medications. And that is not to say that your GP thinks that you're depressed or have epilepsy. We use these medicines for all kinds of things. You might have an anti-seizure medication if you have shingles for pain. You might have them for all kinds of reasons, one of which are menopausal symptoms. So there are lots of options out there. And if you're thinking, I just don't want HRT, therefore I have to manage, you don't. Come and see us. There are lots of things that we can do.
And what about things like, there are a lot of women who suffer with vaginal dryness, vaginal atrophy, which you touched on at the beginning. What would you suggest for that, for sort of extra lubrication? And especially when there's, it can cause painful sex and even pain just sitting down or walking, wearing a pair of jeans.
So I always bring it up in the consultation, because if I bring it up, then it helps women talk about it, because sometimes that can be sort of like the last fence that they don't want to talk about. But just as you can tell women in the waiting room who've got thrush because they give a jiggle, you can often tell because people are so uncomfortable that they can't sit down, that they feel like they're on fire, or sex becomes painful. And if sex becomes painful, that affects your libido, because your libido is a really complicated thing that has physical and psychological parts to it. Because if it hurts, why would you want to have it? And you can get recurrent urinary tract infections and more. The first thing is to talk about it, and there are lots of things we can do depending on the degree of your symptoms. You can start with a good proper lube. Lubricant is the vagina's best friend when it comes to sex, whether or not you have vaginal dryness. And you want to use a brand that doesn't contain any perfume, any kind of glycerin. Glycerin makes things sticky, but it's also sweet, and that can affect the bacteria which are naturally in your vagina and should be. So we want to use a good lubricant, something like the Yes brand. Other people find Silk, SYLK, helpful. And you can actually use, as long as you don't need to use condoms, you can use oil-based and water-based together, because one glides over the other in what's called the double glide effect, and that can be helpful. And so if you're only having symptoms during sex, that might be a good start. Other people, or even if you're just having symptoms during sex, will need a vaginal moisturizer. And again, you want to be using something that doesn't contain any irritants or perfume in it. But actually, for lots of people, the answer is vaginal estrogen. Now, vaginal estrogen is topical, so it goes into the vagina and it only acts locally. And it is absolutely life-changing for women. And we know that the risks with it are so small that actually they are considering making it available over the counter in the UK. And that is because although technically I am replacing hormones by giving you vaginal estrogen, it's not the same as systemic whole body HRT. And so when you get the leaflet that talks about risks of whole body HRT, but actually none of it's getting absorbed into the bloodstream, people often coming back going, oh my goodness, you didn't talk about any of this. And that's because using vaginal estrogen for a whole year is the same as taking 1 or 2 tablets of oral HRT. And the gynecologists and the urologists and lots of academics actually now say that women who need to have vaginal estrogen should be having it long term, for the rest of their lives, and not be concerned about risks associated with it because they're not there. And actually, even for women, lots of women who've had a hormone dependent cancer, that it can be an appropriate course of action. So there are lots of options there. Sex shouldn't hurt.
Absolutely.
And you shouldn't be uncomfortable the whole time, and don't need to have the misery of recurrent urinary tract infections when we can do something about it.
And you were saying that, women can in theory be on it for the rest of their lives. We do get that question asked a lot in the Latte Lounge, like, how long should I be on it? When should I come off? I mean, what's your sort of view on sort of length of use, I guess?
When it comes to vaginal estrogen, let's go for it. When it comes to systemic HRT, you should, I think, ask that question regularly. And that would be once a year for me. And that's because things might change in the course of that year that disrupt our balance of risk versus benefit. And as long as your perceived benefit outweighs any small risks, and the risks of HRT are there, but they're small, and actually we can mitigate lots of them by the way that we deliver the HRT. So for example, the increased risk of clots in the leg comes with taking oral HRT. If I give you your estrogen through the skin, that risk goes away. But we need to weigh that up each year, and that might change for you, for example, if you develop breast cancer or if something else happens. And so that's why I think it's important to ask the question, but there is no official stopping point for HRT. The answer is you can stay on it as long as you need to.
And also, you said you talked about lifestyle changes, and I guess if we can keep a healthy weight and reduce our alcohol and giving up smoking, then obviously you're reducing other risks. And so, as you say, it's balancing
bearing in mind that alcohol is very closely associated with breast cancer. Actually. And so, yeah, these are things that we need to do. And experience sort of shows that women who are on HRT and feel happy and good in themselves are more likely to be able to eat a better diet, are more likely to be able to exercise, and so actually sometimes it's a bit chicken and egg, what's causing what. But I think that it's just an important conversation to keep having. And just as no one should be making you take a medicine in this particular situation, as long as that perceived benefit is greater than the perceived risk, no one should be saying you absolutely must come off it.
Absolutely. And that was actually my story, gained 4 stone in weight no matter what I did during that perimenopause sort of low time. I couldn't lose it, but as soon as I felt better and my hormones were balanced, actually I had that kind of get up and go and joy again in life, and wanted to embrace it. So as you say, sometimes things like taking HRT may be the final piece in the jigsaw when perhaps nothing else is working, or the other way around. So it's about individual choice and having that kind of one-to-one consultation with your doctor, who will hopefully be like you.
And that also means, though, that what's right for you is not right for your best friend, and not right for your sister, and probably not right for your mother. And we're all influenced by those sort of people. And bearing in mind that the WHI study came out about 20 years ago now. And so that's often about the age that your mother might have been going through the menopause, when HRT was hugely demonized. And we know much more now than we did then, but that was the message that she might have heard very strongly. And so, there are lots of voices that we hear as women going, you mustn't have that. But in the same way that also, lots of people were told they mustn't have a coil before they've had a baby. And actually, we know that's not true. And so it's important that you get your information checked.
Yeah, trusted, reliable sources. And talking of trusted, reliable sources, tell us about the book that you've written and why you wrote it, and where women can get it.
So I've had it here. It's called The M Word, Everything You Need to Know About the Menopause. You can get it anywhere and everywhere that you buy books. But I wrote it because I saw a need. It came out a couple of years ago now. And I was seeing patients in my clinics every single week. And when I talked about their symptoms being possibly related to the menopause, people didn't know. And people still don't know. And, there's wonderful documentaries at the moment, and there's a huge uptick in media coverage, but still there are a lot of people that don't know. And so lots of, listeners to this podcast might be going, yes, we talk about this all the time, and that's wonderful, but we have to talk about this more all the time, because there are still so many people who aren't aware of the impact. And I wanted to provide an evidence-based resource where, we just talked about a trusted resource just now, that I had researched the information to ensure that what people were getting was correct, because there is so much misinformation out there. And I have been delighted at how well it has been received, and I hope that if anybody listening uses it, I hope that you find it helpful.
It's an absolutely brilliant book, and there are just so many communities, and there's a lot of religious communities, women and their partners who aren't even on social media, who perhaps don't watch television or have the time to even read the news. So having this book to just read in the privacy of your own home and empower yourself is just so important. So before we wrap up, Philippa, can you give me maybe your sort of final piece of advice for anyone listening, and also tell everyone where they can sort of read more about you if they are online?
So if you want to follow me on social media, on Twitter and on Instagram, I am at Dr. Philippa Kaye, and I have a website with various books on it, and I post lots of stuff about women's health on my Instagram. My final piece of advice is not actually just about women's health, it's about all health, which is you have to know you're normal. You have to know what's right for your body, and the only person who knows that is you. And that might be how often you do a poo, it might be how often your periods come, it might be what your vaginal discharge looks like, and it might be how you feel inside your head every day. And when that changes, no matter what that change is, be it a breast lump or irritability or my periods are coming every 2 weeks, what the hell is going on? If that changes, that's the time to go and ask for help.
Brilliant piece of advice. Thank you so much, Philippa. And I hope that's helped everyone who's listening. And thanks so much again for joining us, Philippa.
Thanks for having me.
If you've enjoyed this podcast and would like extra support with managing your menopause symptoms, then why not consider becoming a Latte Lounge member? Members get access to members-only masterclasses with medical specialists and wellbeing experts, members-only content, how-to guide and resources, plus a chance to connect with other women just like you in a warm, friendly, private community. Podcast listeners get to join for just £10 for the first month. See show notes for more details. Thanks for listening to the Latte Lounge podcast. Please subscribe wherever you're listening so you don't miss our next episode. For more support with all things menopause and midlife, head to our website lattelounge.co.uk and search for the Latte Lounge group on Facebook. This podcast was sponsored by Silk Natural Lubricant and produced by Emily Crosby Media.